My name is Stephen Smith. I work in British Columbia, Canada for the Ministry of Health there. And for those who've looked at the syllabus in advance of today's presentation, I was supposed to be co-presenting with a colleague in British Columbia, Debbie Sorry, who couldn't make it today. What's significant about co-presenting with her is she actually represents the Ministry of Children and Family Development of British Columbia. And like many jurisdictions, the responsibility for the delivery of mental health care services is split between the Ministry of Health, which focuses on adult needs, and the Ministry of Children and Family Development, which focuses on child and youth needs. So it's significant that we've been leading this project together as the co-chairs of our provincial Family, Mental Health, and Substance Use Task Force. And I'll tell you a little bit more about the task force shortly. I did want to start by acknowledging that I am an advocrat, to borrow that phrase from the plenary this morning. I feel very strongly that I take every opportunity to advocate in the context of my bureaucratic responsibilities. The other thing I wanted to mention on this first slide is that the beautiful diagram here, which really conceptually represents family mental health, is a product of the Force Society for Kids' Mental Health, which is an NGO in British Columbia that does tremendous work in this area and has been quite instrumental in terms of moving this effort forward. So, I think I'm going to get this to work. So we'll do it over here. The syllabus also didn't include the learning objectives, so hopefully these all resonate with folks so that there isn't any major challenge in terms of what we're hoping to accomplish today. Just to set the stage, what I'll be talking about today is yet to be released, yet to be published policy document on family mental health and substance use. The foundation for this work really was our provincial mental health and substance use plan, which was released in November 2010, Healthy Minds, Healthy People, which was a transformational document for mental health and substance use in British Columbia. For the first time, we had as much emphasis on opportunities for health promotion and prevention as we did for care and treatment of mental health problems and substance use problems in the province. But half of the actions within the document actually focus on prevention or mental health promotion, which is fantastic. And it also explicitly gave us the opportunity, the space to focus in on parental mental illness and some of the challenges associated with preventing transgenerational mental health problems. Through this particular action and a deliverable that was missed slightly. I mean, we're in 2014 now, and we're just expecting that this resource will be out shortly. However, there's been work that's been seeded by the development of the document that means we've actually in effect, been able to realize some of what was intended through this outcome in the document in advance of our policy document being released. I also want to acknowledge that as a foundation to our work, we have a long history in British Columbia of interest in the issue of COPD, or children and parents with mental illness. And we've had a working group in the province acting as an informal community of practice for almost 2 decades now. Some very good minds have been really focused on where the opportunities exist to move the best evidence, the emerging practices around COPD forward. And they've done a tremendous amount of work. Their work has been reflected through a dedicated website and various initiatives that we have undertaken in the province. And a number of the individuals who are involved in this community of practice have become core members of the working group, the task group that I'll be talking to you about right now. So, in order to do the action in Healthy Minds, Healthy People that reflects the needs around parents with a mental illness and the family vulnerability that corresponds to that, we decided we needed to actually pull together a group of folks from a variety of disciplines and a variety of sectors, because we understood that this particular work couldn't be undertaken by government alone, or by community alone, or by service providers that were publicly funded alone. We needed to have a mix of those people at the table who were working in a real collaborative and equal kind of way to bring forward the best thinking and identify the best opportunities in order to do this work in BC. So we formed a task group to focus on family mental health and substance use. It was, as I mentioned, originally focused on parental mental illness, but we made a decision that I'll speak about shortly to expand that to family mental health and substance use. And And I'll show you actually the folks who are around the table currently. There are about 3 representatives from my ministry that represent various departments. I'm from public health, and there are a number of folks from mental health and substance use and other departments in the ministry. Our health authorities, which have responsibility for delivery of health services, particularly adult mental health and youth mental health and substance use services in the province, are represented around the table. The Ministry of Children and Family Development is represented at the table, both child and youth mental health, and also child welfare and child protection as well. And Ministry of Education is represented, and we have several key non-governmental organizations and groups representing civil society, as well as professional organizations representing, for example, the clinical counselors of British Columbia. So when we were developing this document, we started from a place where we looked to the literature, both peer-reviewed and grade literature, in order to determine what was out there that we could draw on as best practice examples. We also looked to the experience of practitioners in BC and other jurisdictions. So we drew the experience in non-published formats as well, through conversations with practitioners. We talked to policymakers and service providers around the province, and most importantly, we sought input from families directly, because we knew that the lived experience of mental health and substance use challenges was going to inform this document in a very direct way, and should inform this document in a very direct way. So we really valued that input. We got it from a variety of places, through a variety of processes, and because of the NGO membership on the task force, we continue to have the voice of families who are affected by a problem represented in the ongoing development and soon to be implementation of this document. And so the structure, the basic structure of the document emerged from a very focused planning session, and has really been a work that has evolved from the basic goals and operating principles that were hammered out through that planning session initially. I want to also acknowledge, and for the folks who were at the last one of these conferences, you probably got a chance to be at the, hopefully got a chance to be at the launch of the Families Matter framework in British Columbia, which was developed by the Force Society for Kids Mental Health. I want to acknowledge that this document really acts as the basis for, or the mandate for Families at the Center. The Force's document, the work that they did to develop this document really undertook a very sort of thorough and comprehensive engagement process with families in order to determine their needs, what they felt systems needed to do better in order to support them, and what they felt the priorities for action were in terms of public system support. So we look to Families Matter as the voice of families, telling us what they want. And Families at the Center, we conceptualize as the service system response to Families Matter. So we see them as really complementary resources and kind of bookending our overall response. I do want to also acknowledge that there was a lot of work underway in the province to respond to challenges related to domestic violence and untreated mental illness and severe substance use problems among some families. And although we didn't want to make this particular focus the emphasis of our document, we needed to make sure that whatever we were doing in Families at the Center acknowledged and accounted for the emerging work that's happening related to these initiatives. So it's really informed and aligned by these documents, but certainly doesn't begin and end with these particular issues when it comes to family mental health and substance use. And likewise, our Safe Relationships, Safe Children's process and prevention of domestic violence plan. I also need to acknowledge that we spent a lot of time making sure that this document would align with work that was underway to really implement a patient-centered graduate orientation. And we really think that this expands on that work in a very significant and interesting way. Practice guidelines of the Ministry of Children and Family Development around trauma-informed care, and an emphasis on trauma-informed practice within the adult system, and the specific initiatives that are already underway in some of our health authorities related to implementing a family-focused approach. The vision for our document, which we hammered out in that initial planning session I mentioned, is families and older diversity are at the center of service system cultures and responses. And we hope to actually accomplish this vision in two ways, by helping systems and their representatives to adopt a family-centered approach. And Daryl spoke to some of the challenges related to that. And those are challenges we're grappling with right now in terms of an implementation plan. So it was really timely to hear about what's happening in Victoria around that. And then ensuring greater collaboration among all systems that touch and influence the lives of these families. And I mentioned that many of the groups, or many of the members around the task force table represent different policy perspectives, different ministries. We continue to engage other public sector partners in the context of development and implementation. The conceptual basis for the document is this particular diagram, which is called the Spectrum of Family Engagement. This is an adaptation of the Spectrum of Public Participation, which the International Association for Public Participation developed. And we really spent some time working through this diagram in order to represent a number of stages of engagement for families within our public systems. And you can see that there are arrows representing greater opportunities for benefits and more opportunities for support and involvement as we move through these various stages, and the colors get more intense. At each one of the steps, we chose to undertake a description, or develop a description about the orientation to the system at that stage, the engagement goals for the family, the system's promise to the family, what systems were actually saying they would be able to deliver to families, and what the families were perceiving they were receiving, or what they were actually getting as a result. And our task force felt it was very important to include a column that represented a non-desirable place, which is our exclude column. So that's a real individual focus, which is of course where most of our systems, or many of our systems, start from. We wanted to ensure that that was really appropriately categorized as exclusionary and separated from the other steps. And one of the important pieces that we really kind of emphasize in the document is that there is an understanding that this is a progressive kind of movement, that many services or many service providers or many clinicians will never be able to meet what we consider the empower stage in the spectrum. But any movement from left to right is desirable, and people can actually see, where their current practice sits and where they might want to move to in terms of an actual orientation. And likewise, individual families might have different needs and necessitate a different approach in any of these columns as well. So it's a fluid continuum. It isn't a rigid kind of unidirectional continuum. So the key elements of a family-centered approach, we really kind of built on some fine work that's already been undertaken by the Center for Addictions and Mental Health in Ontario, and they developed some really interesting tools and resources for family engagement and family involvement. So I won't read through these in literal detail here, but I'll just let you have a quick look at them. In essence, really, the core elements are around partnership. They're about involving families as important contributors to the planning and to the delivery of any care and treatment services or any supportive services that are offered to the individual that's affected by a mental health or substance use problem. And there's also a real emphasis on looking at the entire family in a holistic kind of way. And again, I mentioned that the task force moved from a parental mental illness focus to a family mental health and substance use focus. There are two pieces to that I really want to explore with you, which are really fundamental to our document. One is that mental health and substance use. We really wanted to not focus on mental illness, but focus on mental health and really look at opportunities that would allow families, would equip them to thrive. So not to focus on the deficit, but really to take an asset-based kind of approach. And also to look at all members of the family and all their needs, not just the individual that is affected by a mental health and substance use problem. And that meant that we needed to look at the complexity of the various relationships in families and where problems may occur and corresponding vulnerability pathways. So really we're looking at a kind of a hybrid of the COP-me and PAC kind of approaches, the POC-me approaches that we've heard about in the plenary today. So the document itself, this is the core set of components. We have a vision statement. There are some values that families really actually developed for us. That values that are in our document are taken right from Families Matter and really reflect the voice of families. Our goals we'll get to in just a moment. Operating principles reflect the input of service providers, what they felt needed to be at the core of what they're doing in order to transform the approach or the efforts. And focus areas, there are 4 focus areas which I'll speak to, which correspond to opportunities for action, and I'll speak to those as well. So our goals, we're really focused on supporting families affected by a problem to thrive. So that's the essence of what we want to do. It's not just about supporting better care treatment, supporting recovery. It's about actually getting people to a place, all members of the family, where they feel like they're thriving despite the challenge that they face. We also want to minimize any particular harms that may be associated with any of the challenges that are experienced within a family unit. And wherever possible, we want to combat on a systemic level the stigma and discrimination that are experienced by families who are accessing various services through public systems. We have 4 areas of focus within the document. The first 2 focus on opportunities through specific initiatives and programs and service systems. First, really being the upstream promotion and prevention, harm reduction kind of services, and the second being the more formalized care and treatment services and supports within our systems. But we also wanted to place equal emphasis on collaboration and coordination across systems and sectors, because we knew that that was fundamentally important to success. And we needed to place a significant amount of emphasis on knowledge exchange and workforce development, because we heard all the same challenges that Darryl articulated from folks in the field around how this shift represented a huge challenge in terms of orientation and practice. Each one of those 4 sections has a number of actions or opportunities for actions nested under them. There are 16 recommended actions in total within the document. And each one of the actions is supported by some examples that we've highlighted of promising practices and resources. So whenever we ask people to consider an action to change the way that they approach their practice or the way they organize their work, we offer, wherever possible, wherever they exist, some examples of resources or initiatives that are already underway, or literature that describes an approach that can help them grapple with that change. So we're actually at the point where we're grappling with change at a fairly high level. We're just expecting that this will be approved probably within the next month or so. So release is anticipated sometime before the summer of this year. And we're starting our implementation plan, looking at the opportunities to support change management across the various systems. Really looking at workforce development in a very direct way. And so what does that mean in terms of supporting practice, building confidence for practitioners, unpackaging things like privacy legislation and what the implications are, and what some of the misunderstandings or misperceptions are around privacy legislation, because there are a lot of those that play into that lack of confidence as well, too. We're looking at the introduction of accountability measures that can drive change on more of a systems level, and looking at work with researchers and representatives of families, so the families are informing our research agenda as well, to find ways of evaluating our implementation success, and also what the outcomes are for families as we move from a patient-centered focus to more of a family-centered focus in terms of our engagement of families affected by these challenges. So that's it for the formal presentation. Any questions?
I'm curious about where we may be able to access this document when it comes out. Will it show up on our website, right?
Yeah, it will be posted publicly and probably on 2 websites, the British Columbia Ministry of Health website and the British Columbia Ministry of Children and Family Development website. Potentially more, but at least those 2. Yes?
I have a very specific question. I'm from British Columbia as well.
Yes.
Was CLBC involved in any of your consultations?
Yes, they were invited to the consultations that initially developed our goals, our approaches, the structural framework for the documents. They haven't been members of our task force, which has really been the fine-tuning of that as we've been developing that.
can I add to that?
Yes.
The Family Matters framework, I was part of the group that went out and collected the initial data for that framework. And we went around to the province and we opened it to all community members. And there were representations from all different parts of that story around families dealing with disabilities, as well as adult mental health issues, as well as child mental health issues as well.
Just for the other people in the room, that entity is the entity that deals with adults with developmental disabilities.
I hope this is relevant to what I was listening to. I wanted to know if you had any advice. When I listen to these things, they're often started at a higher level with people who are employed and it's a project grant funded. Right now, a hospital in the state of Oregon that is regional throughout the state never had family, or I'm a parent who has mental illness, they never had family involved in any decision making. Council was just created 8 months ago that I became a part of. I'm the only person on the council that is on disability, that does not work for some, hospital or anything like that. And I'm the only person on the council. I was put as chairperson of Parents with Mental Illness because I was the only person who gave a crap about it. And at the same time, I'm also hearing from a lot of people through these hospitals because people trust me to tell me these things. The council that you're at is not wanted. The hospital does not care about it. The view of many of the people who work at this hospital is that people like you who have mental illness, your perception's skewed, you don't really know the reality of everything. So I got a wall at me already, that's already there. Just any particular advice of when I'm not at your level, but I'm at this level, how do I get, even just a piece of kernel of advice to
Don't
get
give up.
the doors open? I haven't. I got a policy was created, but it took over. They didn't have any support for breastfeeding mothers, and I was traumatized by my experience of not getting support. It took over 1.5 years to get them to listen until something finally got on paper. And my biggest fear is that, yes, it's on paper now, but is it getting shelved into a file drawer, or is it actually getting implemented as parents come through the system? But I got walled off. I got walled off by the people who actually laughed at me about, I had professionals laugh at me about some of my experience, and I got walled off by professionals saying, you know what, you're not us, you don't work here, we don't want anything to do with you. We'll take care of it, see you later. So it's hard from that end.
It sounds very hard, very frustrating. And one observation I can make is that something we heard right from square one from families that we were talking with and working with was, this represents a huge cultural change. And we know that that's the case. This is quite counterculture to the way that our service systems are structured. And so culture change doesn't happen overnight. It's a gradual kind of thing. So as Daryl said, keeping at it is really important. Understanding that sometimes cultural change is very threatening for folks is important for you, I think, just in terms of helping to understand why there's resistance to, because sometimes it's because it threatens.
That's the hard thing too. I got informed, even when I was having this treatment, I was getting informed to, keep my advocacy hat off. You're a patient, we don't want to hear from you at that level. And I got informed to keep quiet. I had psychiatrists telling me, you know what, they don't like to be challenged, just keep quiet. And so I'm trying to come at it from can we work together? But they don't want to, so it's very difficult.
You may want to contact the Center for Independent Living in Portland. They may be interested in working with you on this as an advocacy issue.
Maybe the force.
Need some friends and help as well.
I'm also wondering, you have a goal about addressing discrimination.
Yes.
One of your things.
Yes.
I'm just wondering if you had any input during your consultations from the family law perspective, and from we know about cutbacks in legal aid in British Columbia,
Yes.
particularly in the area of family law, from that kind of source, the Canadian Bar Association or anything like that.
Limited, but what we want to do as we continue to think about our implementation plan, because it's going to be multi-stage, what was very helpful actually coming after Daryl's presentation was to see that pyramid and to look at that bottom level where we're talking about workforce in terms of confidence, addressing confidence levels, and really kind of what is needed in terms of tools at that stage or that level. I think we're starting there, but we anticipate that we need to do a lot of work as we continue to move up the pyramid, and we need to engage, exactly as you said, family law experts in terms of the systemic discrimination, because sometimes you can change policy within institutions so that it makes it more difficult to discriminate. It doesn't completely eliminate it. We need some advice on how we can actually do that on a more systemic basis.
Thank you.
Any other questions? I think we're close to transition at this point in time.
All right.
Thanks.
Well, thank you very much, Steve.
Thank